Okay, so we're talking about quiet breathing, and we've just explained that inspiration is the result of two different muscle groups contracting to change the volume of the thoracic cavity. The lungs are already under a pressure differential. The thoracic cavity is under negative pressure relative to the lungs, so the lungs stay inflated. If we make the negative pressure even greater by changing the volume of the intrathoracic space, in other words, in this case, making the volume bigger, the pressure gradient is even greater and the lungs will inflate. And as they inflate, they pull air in from the atmosphere. So that's inspiration. And for expiration, we just have to stop the muscle activity. In other words, expiration at rest is passive, and that will last 3 seconds off. Okay, now I picked seconds just because at rest, respirations are probably somewhere between 12 and 16 per minute. If we do our 2 second, 3 second ratio, that's 5 seconds, that's 12, right? 5 times 12 is 60. So that fits this ratio. If we're breathing at rest a little closer to 16, the ratio remains 2 to 3, but it wouldn't be 2 full seconds or 3 full seconds. Everybody follow me on that?
Yeah.
Okay. So in forced expiration, forced ventilation, that's what's going to happen during stress or fight or flight, exercise, those sorts of things. We're going to recruit. Okay, so for example, on inspiration, we're going to add pectoralis minor. Our scalenes, those are the muscles in the anterior part of the neck, and our sternocleidomastoid muscle, that big muscle that you can see on either side of your neck that stands out. It runs from the back behind your ear, the mastoid process, that's where the name's coming from, and inserts itself down on the sternum at the junction between the clavicle and the sternum in that area there, sternoclavicular or sternocleidomastoid for that muscle. So those muscles will help to expand that thoracic cavity. So they're recruited to help expand that thoracic cavity even more vigorously. And on expiration, because now we want to increase our total ventilation rates, we're going to recruit muscles to help us with the expiration phase as well. Anybody remember what gets recruited there?
I want to say the abdomen.
Okay, well, close, because the abdomen doesn't actually contract, but rectus abdominis does. Right? You follow right? You're happy with the fact that the abdomen itself doesn't contract, right? Only muscles
Yes,
can.
I got it. Thank you.
Yeah, only muscles can contract. That's all I'm getting at there. Some people will say that's getting pretty picky, but you know what? By now, you know, sometimes I'm kind of picky, but in reality, it's just being accurate. So in addition to the rectus abdominis muscle that'll contract, and when it contracts, what it does is increase abdominal pressure. And when we increase abdominal pressure, we're going to push the diaphragm back up into the thoracic cavity. So when we increase pressure in the abdomen, we're going to decrease or reduce the longitudinal. I'm not going to get that written in there. Not that you can. We'll just say reduce your longitudinal distance there. And the second group of muscles that we're going to recruit are essentially the antagonists to the external intercostals, which are the internal. Intercostals. So if the external intercostals lift the ribs up and out, the internal intercostals are the opposite of that. They're going to be able to pull the ribs back down and in. So we're going to decrease the AP distance, anterior to posterior distance. So thoracic volume decreases. And we know that ratio, that relationship between volume and pressure. If we decrease the volume, we're going to increase the pressure. That's going to push air out. The lungs will be squeezed a little bit smaller and air will be forced out. So in forced ventilation, we see recruitment of muscles in both phases, inspiration and expiration. And in passive or quiet breathing, the expiration phase is simply a passive phase. We just stop signaling the muscles that are responsible for inspiration. Okay, and that's all controlled up in the medulla oblongata, and override occurs with the pons. The pons gets more involved when we're not resting. The resting is sort of established by groups of neurons in the medulla oblongata, and when we change out of rest, we're going to have input from the pons. And remember, the medulla oblongata has got receptors that are sensitive to carbon dioxide in particular. Remember, receptors we found in the central nervous system, we called them central receptors. And there are receptors that are most sensitive to carbon dioxide. So the drive to breathe comes from rising levels of carbon dioxide, much more so than rising levels or lowering levels of oxygen. Seems a little odd, but our regulation, our homeostasis of carbon dioxide levels is much more sensitive than it is to oxygen. And that reflects the fact that we talk about our systems, especially when we start talking about pathology, we like to talk about how our systems are overbuilt. And you might remember that when you talk about oxygen delivery to the circulatory system from the alveoli, that we load up oxygen, and if we saturate hemoglobin 100%, a full circulation, a full systemic circulation just drops off about 25% of oxygen that was being delivered, which leaves us with this reserve of 75%. When we get back up to the lungs, we just have to reload the 25% we dropped off. So it's efficiency. We can drop, down to say 60% instead of 75% and still maintain, especially at rest. But much below 60% of saturation becomes a bit of an emergency, becomes a problem. If the lungs are, because now there's more that needs to be loaded up at the lungs. And that came from that oxygen saturation curve. You might remember talking a little bit about that in HAP 201. Let's see here. I have that right here. So when we look at this picture here, we can see that we've got a sort of a lazy S or part of an S-shaped curve. And when we have complete saturation, if you look at the hemoglobin going up the side, and we look at complete saturation, that occurs around a PO2, in other words, arterial blood, that might be, as we get around 80 or so, a PO2 of 80 to 100 is a pretty flat curve, and it's pretty close to 100%. It may not be quite 100%. We consider, and you guys know this from your labs and clinics by now, that what's considered a nice healthy oxygen saturation, arterial?
Greater than 93.
Yeah, so we say 95 to 100, right? Give or take. Whether 93, we're not going to get too concerned about that. But the point being that as our PO2, arterial blood, approaches 100, saturation of hemoglobin is already at 100 or very close to it. So we don't need 100% saturation of the arterial blood in order to have 100% or normal saturation of hemoglobin in that 95 to 100 range. Probably never gets to truly 100, but it's going to be at 99 or in that range there, somewhere between the low 90s to the high 90s. And we can see that as we approach good arterial partial pressures, that we're leveling out. So much after you get up to a PO2 past, say, 75, you're not seeing a huge change in the loading onto the hemoglobin. But if we look down here, this represents venous blood. So when we've delivered oxygen to all the tissues in the body and we're returning the venous blood back to the heart, the PO2 of venous blood is around 40, and we can see that makes our saturated hemoglobin at about 75%. We dropped off about 25% to all the cells and tissues in the circulatory pathway, and we have to reload that at the lungs. Does that make sense? Do you see how to read this for what we're talking about right here? We okay with that? Yeah. Okay, and then this number right here, this just represents an example of what's happening if we're exercising. So 40 is what we see at rest. But if we're exercising, we might drop off quite a bit more. The demand is much higher by the cells and tissues in the body. So the venous blood returning back might drop as low as a PO2 of 20. And we can see that the hemoglobin is going to be much more reduced of oxygen carrying capacity in the exercising venous blood. You might drop down to about a 35 in this example that we're looking at right here. And that's just a reflection of the increased demand during exercise. Are we okay with that? You okay reading that based on what we're talking about there?
Yes, thank you.
100%.
Okay, great, good. So what else do we need to remember about our normal respiratory system so that it'll help us explain what happens when we have abnormal scenarios? Let's take a look at what do we get here? Not yet. Let's take a look at our gases here and just be comfortable with these partial pressures that I was mentioning. So in our atmospheric air, we've got partial pressures in the atmospheric air that represent extremes of the oxygen that we see systemically. So when we breathe in air, by the time it gets down to the alveolus, a partial pressure in the alveolus for oxygen is around 100, and for carbon dioxide it's around 40. So these create gradients. When the venous blood is returned, when the venous return is occurring, and I'll use this, here's our venous return, and we can see that the partial pressures of oxygen and carbon dioxide are represented here. Carbon dioxide is sitting around, I usually round it off to a 45. They've got it in this particular diagram at 46. That works fine for us. So we have a partial pressure of 46 in the venous blood for carbon dioxide and a partial pressure of oxygen of 40 on the venous side. Okay, now that fits with what we were showing on our O2 sat curve that we just talked about, but we can see that we've created gradients. So now when we are exposed to the alveolus, and remember that the membranes of the alveoli and the membranes of the pulmonary capillaries are the smallest possible distances that there can be between two membranes, which makes the exchange location very, very effective. So we have an alveolus that's a simple squamous epithelium. And we have a capillary that's a simple squamous epithelium. So if we have a partial pressure of oxygen of 100 on this side, and the partial pressure of oxygen is 40 on this side, then we have a great concentration gradient that's going to favor movement in this direction. Gases don't require channels or special passageways. They can dissolve across those membranes. So we can appreciate that there's a few other mechanical barriers that are part of this. The space between the two tissues, the interstitial space, which is fluid filled. There's some surfactant that would be on the surface of the alveoli, and a basement membrane for each of those simple squamous epithelia. So there's a few more barriers than just the simple squamous epithelium, but all tissues would have those in addition to added layers. So this is still representing the most efficient communication we can have between two separate tissues for exchange to occur. Short distance, leaky vessels in each of those cases. And the same is true if we looked at our partial pressure for CO2. We said it was 46. If we're going to just copy the one from the diagram that we're looking at, and it's a 40. So again, we have a partial pressure gradient that favors moving in that direction. This was our alveolus, so the CO2 is going to be breathed out, and the oxygen was delivered to the circulatory system. Ventilation, perfusion. And you might remember that there's such a thing as a ventilation perfusion ratio. The symbol that's used for blood flow is a Q, a capital Q. So this is a ventilation perfusion ratio. And ideally what we want is a 1-to-1 matchup. Now it's not going to be exactly 1-to-1, and it will vary a little bit by gravity and by the health of the respective tissues. But the goal is to try to match ventilation with perfusion. So if we have a scenario where ventilation is reduced, if we're interested in maintaining a 1-to-1 ratio, what's going to have to happen to perfusion?
It has to also be reduced.
Yeah. Okay, so that has to happen in order to try to maintain that 1-to-1 ratio. Okay, and you can reverse that statement. You can say that if perfusion was reduced, then the ventilation in turn will have to be reduced. So autoregulation, you might be familiar with autoregulation at the tissues. We've talked a little bit about it when we did the cardiovascular system, both in normal anatomy and physiology, but also in pathology. So normally when a tissue is ischemic, it sends local signals, autoregulates, to increase blood flow to that tissue, right? That makes sense, right?
Yes.
Right? So if these cells down here were not getting adequate blood flow, they would send chemical messengers from their cells to stimulate vasodilation, for example, to increase the flow to that particular group of tissues. Right? That's what we normally see with autoregulation. But in the lungs, we see just the opposite. So autoregulation between the alveoli and pulmonary capillaries is opposite to Okay, so I'll show you what we're talking about. So here, we're looking at a scenario where, so this is a schematic just to focus and familiarize yourself. We've got the pulmonary circulation, the capillaries, here in the shown in the red angles, and the pulmonary. So the pulmonary artery is delivering deoxygenated blood to the alveolus to be picked up and delivered to the left side of the heart through the pulmonary veins, right? Veins go to the heart, arteries leave the heart. Okay, so there's our airflow. Our airflow is coming through the alveoli in our two diagrams here. And the idea is we're delivering air down to the alveolus. If the alveolus is wide open and healthy, then we're getting good air delivery, good oxygen delivery to the alveolus. We're going to have good perfusion to that area. Now, in this example over here, we've got a blockage. See, we've created a blockage here. So this alveolus is poorly ventilated. So the pulmonary vein, rather than dilate, which you might expect to see if it was down at a tissue, we're going to see a constriction. And the goal of the constriction is to try and reestablish that 1-to-1 ratio. In other words, we're not going to flow blood to an area that's poorly ventilated because exchange isn't going to work. It's a waste of energy. It's a waste of attention in the lung tissue. So if we had a blockage because of an asphyxiation or a blockage because of some sort of an embolus, in this case, it would have to be an air embolus of some sort. So think asphyxiation or a mass that might be growing in part of the airway that reduces the ventilation. If we reduce the ventilation, then we're going to, in response to that reduced ventilation, we're going to see vasoconstriction. We're going to see blood flowing away from that area. You follow me?
Yes.
Yes.
Okay. And the same concept applies if we had poor blood flow to an area. Okay, then we're going to redirect blood flow away. Sorry, we're going to redirect airflow away from that area because, again, it's a waste of efficiency. So you could have a poor blood flow from what we were talking about in the cardiovascular system, a pulmonary embolism that blocks blood flow. So we're not getting good blood flow to this section of the lung. We're going to redirect the airflow into the areas where we have good blood flow. So think of the match. We're always trying to fix the match or correct the match to be as close to 1-to-1 as possible. So if we have a pathology in airflow, we're going to make adjustments to blood flow. And if we have a pathology in blood flow, we'll make adjustments to airflow. Okay, so the goal is always to try to maintain the ventilation perfusion ratio as close to 1-to-1 as possible. If you remember that, you can figure out the adjustments that need to be made, depending if it's an airflow problem or if it's a blood flow problem. Okay. So what else do we need to be comfortable with? Oh, let's just review very quickly the alveolus. Okay, so here's our exchange. Those are those layers I was mentioning, the endothelium of a blood vessel, the endothelium, the epithelium of an alveolar. If we look a little closer at an alveolus, okay, in this diagram right here, here's an example of one alveolus. Remember, alveoli are clusters. They look like grapes with a very good blood supply all the way around them. So a single alveolus is a simple epithelium. We have two main types of cells that contribute to the epithelium. And we've talked about them already. Pneumocytes 1 and 2. And the pneumocyte 1 is the main epithelial cell. It's just referred to as an epithelial cell in this picture. And the septal cell is the other name for the pneumocyte 2. Sometimes they're called alveolar cell type 1 and cell type 2, but the numbers still apply. So they're not being switched or anything. And remember, the type 2 cell was responsible for making surfactant that lines the inside of the alveolus and helps keep the alveolus open by reducing surface tension, right? So it doesn't collapse every time we exhale. And the other thing about that type 2 cell is that was a location for those ACE2 receptors. And we know from what we've been talking about that ACE2 receptors are one of the targets for the coronavirus variant number 2 that causes COVID-19 in some people that are exposed to it. So this is the type 2 cell right here, and the rest of those cells that are making up this sort of soccer ball shape or appearance are the type 1 cells, the most common ones. And we have some macrophages that circulate around trying to keep that place clean. So if it got past the cilia and the mucus and got past your cough or your sneeze, we still have some immune cells that are sweeping the environment trying to keep it clean so that we don't have any inflammatory conditions that bring with them fluids that would interfere with exchange. Does that make sense?
Yes.
Okay, so what happens if the respiratory system goes wrong? So in respiration pathology, kind of like the cardiac system, when we talk about the cardiovascular system, basically what it boils down to is if we can't get a cardiac output that meets demand, we've got pathology. So the concept is the same. In respiration, if we have insufficiency, that happens, so just generally, when the lungs are unable to deliver oxygen to the pulmonary capillaries, or to clear CO2 from the pulmonary capillaries. So basically that represents an insufficiency. So, and this failure occurs even after compensation. So that's the trick, right? We recognize that, again, this system has a great capacity to adapt. We breathe at 12 to 16 breaths per minute, but we could breathe 30 or 40 times per minute if we have to. That's what happens when we exercise or when we get stressed. We increase our breathing rates a little bit because that represents an increased demand for oxygen. In the case of the lungs, we're only concerned about oxygen. For the circulatory system, it's oxygen plus nutrients. But for the respiratory system, we're dealing with the gases. So this failure can only occur if compensation fails as well. So that might be a failure of muscular activity. It may be an inability to get enough of the gases from the environment. So we have scenarios where we're in altitude or we go underwater, and we have problems with the availability of oxygen in those circumstances. So there's a number of different things that can happen. And when we talk about acute respiratory failure, we're talking about an abnormal gas exchange. So that's the first thing. And that result of that is going to give us abnormal blood gas values. So that's our PO2s of oxygen being close to 100, and PCO2 on the arterial side is being somewhere close to 40, right? So if our PaO2 is less than 60, and you know we're measuring in millimeters of mercury, right? So that when that's described as an insufficiency or a failure, and the PaCO2 is greater than 50. And that combination typically is going to play a role on our pH, our blood pH. And if our blood pH drops much below 7.3, then we're dealing with this is all part and parcel of our blood gas abnormalities. So generally, we're dealing with problems associated with abnormal muscle functions. So, you know, the muscles we're talking about are the ones we mentioned earlier today, the internal and external intercostals, the abdominal and diaphragm muscles. If they're interfered with, if they're paralyzed or blocked from doing their normal functions, then we're going to have abnormal respirations, and so those might fall under any kind of paralysis. Scoliosis, you may or may not know, scoliosis is a lateral curvature to the vertebral column. If it's severe enough, it compresses one side of the thoracic cavity and expands the other one. Either way, we're interfering with normal excursions of that thoracic cavity, affecting our ability to ventilate efficiently. And any kind of trauma that perhaps breaks ribs, if we break ribs, especially if we expose the thoracic cavity to the external environment, we lose that negative pressure advantage. So all those things are going to result in an insufficient ability to deliver oxygen and get rid of carbon dioxide. Different forms of shock essentially are going to reduce the blood flow to the lungs and interfere with the available amount of blood for exchange. And then we look at diseases. That's what we're going to spend some time on today. Diseases like chronic obstructive pulmonary disease, which is really a group of diseases. Emphysema is one of those, but we'll spend some time specifically talking about emphysema and asthma as some examples that interfere with our ability to deliver oxygen. So, what's the concern when we're unable in respiratory? Let's just start with insufficiency, and we'll recognize that progresses if we don't effectively adapt. What we're concerned about is hypoxemia. So hypox is telling you that there is a reduction, it's hypoxemia. So it's a reduction of oxygen in the blood. And the other often pairing that we're going to see here is hypercapnia. So this is decreased O2 in the blood. This is increased CO2. And with the so those two ought to go hand in hand. So we have, in this situation, two variations on how this can develop. In type 1 insufficiencies, we have hypoxemia, but no hypercapnia. So this is most typically going to occur when there is a VQ mismatch, where there's decreased oxygen flowing into the lungs. So an example would be decreased oxygen delivery to the alveoli. So that's your mismatch. Right now we have decreased ventilation. So the best examples of where that might happen would be in altitude. In altitude, that oxygen content, we said in a normal sort of North American airflow, if we're not up in the mountains, we've got almost 160, partial pressure of about 160. But in altitude, that number goes down quite a bit. So we don't have the same concentration of oxygen with every breath we take being delivered to the alveoli. You could have a scenario where you have a pulmonary embolism, have pneumonia, those sorts of things will create an interference with exchange into the blood vessels. So there are scenarios where the problem is an oxygen availability problem. In type 2, we're going to have hypoxemia and hypercapnia, so we have both. And so this is more going to be a ventilation problem. So in other words, not just airflow in, like we saw in type 1, but airflow in and out. So as a result of not being able to blow off the carbon dioxide is going to accumulate. So we have decreased oxygen delivery or availability, and decreased CO2 elimination. So this might occur in scenarios where the airways are blocked partially, like what happens with asthma and chronic obstructive pulmonary diseases and those sorts of things, or scenarios where we have a decrease in oxygen and carbon dioxide delivery exchange. So in certain kinds of pneumonia, that type of scenario, although pneumonia is more commonly associated with type 1, because usually we can still get the carbon dioxide out unless we get close to end stages of pneumonia. So think more along the lines of chronic obstructive pulmonary, and think asthma, because the airways are restricted. So airflow in both directions is going to be interfered with. So if somebody in either of these scenarios, what do you expect will be the response? So we've got a problem with oxygen delivery and maybe a problem with carbon dioxide elimination. So how's it going to manifest? Sorry, go ahead.
Hyperventilation.
Yeah. So we're going to see some compensations, right? So in a scenario where there's an attempt to fix the problem, we're going to see ventilation changes. But if it's a respiratory problem, that might just present itself as labored breathing, difficulty with breathing. And the general term for that is dyspnea. So we might see dyspnea if we have accumulated levels of carbon dioxide and low levels of oxygen in the circulatory system. Then the nervous system is going to get very excited about that. And one of the things that will present early in someone with these sorts of changes would be a headache and maybe some confusion. If it's allowed to progress, they may get restless. Because again, the nervous system may not be able to identify the problem early on, but it's going to become agitated as a result of it. And so, like most things, the neurons are most sensitive to changes in their environment. So a lot of the early signs and symptoms will come from the nervous system as far as that goes. So, yep, so early on we're going to get probably an increased rate and depth of breathing. And later, we may see some signs of poor oxygen carrying capacity in the hemoglobin. So it'll show up as a bluish tinge in the less pigmented areas of the body. So a lower oxygen saturation in the tissues will show up as a bluish tinge, cool and clammy. And when we start to see these things, because these are later advances, this is an indication that any kind of compensation has failed. So this all represents decompensation. And that can lead to dysrhythmias. So hopefully you've had a chance to look at the recording that I gave you on the electrocardiogram and some examples of pathologies. We know that anytime we have electrolyte imbalances or we have other stressors that are going to affect cardiac function, including coming from the lungs, we've got an increased chance for these dysrhythmias to present themselves as well. So how do we diagnose? Well, good news is we can measure blood gases. We can do chest x-rays. And we can do our best to address underlying causes. So in your history, in your examination, you may come up with underlying causes that play a role in why the respiratory system is failing. And for treatment, what do we want to do for treatment? What's the first thing we want to do if we have that option? We want to, with every treatment, ones we've talked about, ones we haven't talked about, what's our first option? Not always available, but what would our first option always be?
Try to remove the cause.
Yeah, exactly. Remove the source. If, for example, the reason that the ventilation is so poor is because there's a piece of meat in the airway, let's start by getting rid of that piece of meat, right? That person's choking and blocking their airflow. So we got to get rid of the source. If we get rid of the source, we fix the problem. So in any scenario like that, what we try to do is remove the source. Later, we'll talk about asthma. There's a couple of different variations of asthma. One of them is caused by allergens. So let's avoid the allergen. If we avoid the allergen, when possible, then we avoid the symptoms associated with the exposure to that allergen. So first option is always to try to remove a source if it's possible. We want to restore ventilation. We may have to do that mechanically on a short-term basis or provide a better environment for oxygen delivery. So we may have to add oxygen to the patient's environment, in other words, oxygen therapy, in order to help with the short-term recovery, if not on a more regular basis than that. Okay, now another thing just to be aware of is anytime we increase pressure within the pulmonary tissues, we increase the chance for a problem. We talked a little bit about this when we looked at cardiac failure, when we look at heart failure, especially right-sided heart failure, because the most common cause for a right-sided heart failure is increased pulmonary hypertension. And the most common cause for increased pulmonary hypertension was left-sided heart failure, if you remember that discussion when we talked about heart failure in that recording. So anytime there's a pulmonary hypertension issue, it's going to interfere not only with cardiac function, but it's going to interfere with pulmonary function as well. So what exactly are we talking about when we talk about pulmonary hypertension? So normally, right ventricle pumps to the lungs. And the right ventricle, we mentioned when we talked about the heart, the wall of the right ventricle doesn't have to be as thick as the left because the afterload to the right ventricle is the pulmonary circulation. And the pulmonary circulation has a much smaller afterload, so the ventricle doesn't have to overcome as much resistance in order to deliver the volume of blood in its stroke volume to the lungs. So normally we describe the flow to the lungs from the right side is high flow and low pressure. So that's flow, high flow, low pressure from the right heart, right ventricle into the pulmonary circulation. So when we talk about a pulmonary pressure, normal afterload to the right heart is somewhere between 10 and 20 millimeters of mercury. We know that on the left side of the heart, the range is from 120 to 80, right? The resistance is 80 in a relaxed blood vessel and can be as high as 120 if it's in its systolic phase, but it's 80 that has to be overcome, right? So if we get a pressure that's greater than about 30, we have hypertension on the pulmonary side. Okay, so it's still well below the afterload that the left ventricle has to overcome, but the right side is not normally having to overcome much more than a 10 to 20 millimeters of mercury pressure. So hypertension occurs for any number of reasons, but when it gets to be about 30 millimeters of mercury, it's described as hypertension, pulmonary hypertension, not systemic. Right, everybody with me on that?
Yes.
Yeah.
Okay, so primary, by now you probably get, when you see that word primary associated with hypertension especially, then you know that it's going to be idiopathic. So there are no obvious underlying causes that are leading to this type of hypertension. But it does, if there is no other identifiable factor, then it's described as being primary or otherwise idiopathic. And then we have pulmonary. Secondary pulmonary is from underlying diseases. So there are underlying conditions, and we know about some of those already. Anybody tell me what one of them is that was in that recording? Technically from last week? Left-sided heart failure. Have you had a chance to listen to that recording? Because that's sort of important.
I don't think I have yet.
Okay, well, that's
I haven't either.
That's honest. So there's a drawing in there. That looks a little bit like this. Okay, and we will do this. And I will explain it. And you can appreciate that probably understanding it is worth your while, since it's in the previous recording and now it's in this one. Okay, so I think we can appreciate that the circulatory system is a one-way flow. Now, what I've done here is divide the heart into its two parallel pumps. So this represents the right heart, that represents the left heart. The blues and the reds are oxygenated, deoxygenated blood, and the exchange is occurring at the lungs. So do you see what I've done with our schematic here? From a functional point of view, I've separated the two pumps of the heart. Hopefully,
Makes sense.
that hopefully is pretty straightforward, right? So the blood flow, if we follow the blood flow, it's going to go from the right atrium to the right ventricle, from the right ventricle through pulmonary arteries to the lungs, VQ match, good exchange of gases in nice healthy tissues, and we deliver to the right atrium, to the left atrium, and from left atrium to left ventricle, stroke volume out, and away we go. We can appreciate that this is the systemic circulation. This is the pulmonary circulation. Now, when I do this, can you see that little pencil moving?
Yes.
We
Okay.
can.
Because I wasn't sure, all of a sudden I'm sort of wondering if you could see that pencil, and I'm circulating and you're wondering what the heck I'm talking about. Okay, so you do see that little pencil. So pulmonary circulation and then systemic circulation. So we can appreciate, if we think about afterload as being a reflection of blood pressure, and blood pressure, the resistance from blood pressure came from blood vessel length and diameter, as well as the thickness of the blood. The blood, that's going to be consistent all the way through. But you can appreciate, just looking at blood vessel length, that our systemic system has a much longer length to deal with. So that alone accounts for a much larger afterload and a requirement for the left ventricle to be a stronger pump. And the pulmonary circulation is a much shorter distance, less gravity to deal with, less distance to deal with. And so the afterload that the right side of the heart has to overcome is much less. So what we're, with those white arrows, we're showing forward effects. So we said with cardiac failure, cardiac output was reduced. Doesn't matter what type of heart failure you have. The definition of heart failure is a reduced cardiac output, failure to meet demand for any reason that is from heart function. Okay, so that's our forward effect with a heart failure. Backward effects are what happened behind that problem. Okay, so during heart failure, we can have problems that were described as systolic. So if it's a systolic problem, it has to do with the strength of the cardiac muscle, because systolic was the contraction phase of the cardiac cycle, right? So if there's a systolic problem, then it's a problem with the ventricle. If it's a diastolic problem, then it's a problem with preload or venous return, because that's what's happening during the resting phase. Blood is returning to the ventricle. So either not enough blood returns, not enough stretch on the ventricular wall, those sorts of things would be described as diastolic failures. Does that make sense? We okay?
Yep.
Yeah, and
Yeah.
what were the systolic reasons for heart failure?
So what are some systolic reasons? Is that what you asked? I just
Yeah,
didn't.
like what did you say before the diastolic portion?
So systolic would be a contractility problem.
Okay. Thank
because
you.
it's during the systolic phase of the cardiac cycle, which is the contraction phase. So if we have electrolyte imbalances, if we have scarring on the ventricular wall that weakens the contraction, those sorts of factors would be systolic issues that will lead to heart failure. All of that stuff is in that recording, but it plays a role in what we're talking about right here as well. So forward effects in cardiac failure mean cardiac output is failing to meet demand. Doesn't matter where the problem started. If cardiac output has not met demand, that's by definition cardiac failure. Now we want to differentiate between whether it's left-sided or right-sided failure. And that depends on which part of the heart pump is affected. So when it's left-sided heart failure, we know we're not going to have good cardiac output. But when we look at the backward effects, so this is how we differentiate heart failure. And it would help a lot if you had listened to the recording. But backwards means we're just going to go behind. So if it's a left-sided problem, when we go backwards, look where we go first, to the lungs. And then to the right heart. Okay? And more specifically, if we said we had a pathology, I'm going to draw this as scar tissue. Let's say it's from a heart attack. So now we have a problem with contractility. The heart is not able to contract as strong as it did before because there's a bunch of dead cells there. No more cardiac muscle cells. And what that means then is there's going to be fluid left over in the ventricle. Now, I know for those of you that didn't listen to the recording, this is going to go a little bit beyond you, possibly. And that was sort of why I worked hard to get that recording done on time, so you would have time to review it. So normally we had that ejection fraction that we talked about, and it's normally say at 70%. But if there's a contractility problem and it drops down to 40%, what that means is we're going to have a lot more blood left in the ventricle. Everybody okay with that?
Yes.
Yeah.
So that really means there's increased pressure in the ventricle, which is going to go backwards. It's going to interfere with the atrium. And what that means is the pressure in the atrium is going to increase, which is going to interfere with blood delivery back to the atrium from the lungs, which means that we've got increased pressure going back towards the lungs. This is the point I'm trying to make with this scenario right here. At rest, in a healthy tissue, it's somewhere between 10 and 20. But with this backward effect from left-sided heart failure, we get hypertension in the pulmonary circulation. And that goes back and forces the right ventricle to try to overcome it. The right ventricle is not designed to overcome it. So it's going to fail. So the most common cause of right-sided heart failure is left-sided heart failure, based on this backward sequence of events. Does that make sense? Do you follow me on that?
Yes. Thank
Yep.
you.
Yeah.
Okay. So that's the second half of the one recording kind of summarized right there. Okay. And in theory, what's going to happen is we're going to keep going backwards. So the signs and symptoms of somebody with a right-sided heart failure is systemic edema, right? Because now we've increased pressure in the systemic veins. So swelling at the ankles, jugular vein distension, all those sorts of things are telling us it's a right-sided problem. But in this case, it started from the left. And in the left-sided problem, it went to the lungs. So somebody that has left-sided heart failure have symptoms in the lungs, like edema in the lungs that causes noisy breathing, rales, right? That gurgly sort of sound that you can hear with a stethoscope, and if it's severe enough, even without a stethoscope. So left-sided heart failure shows up with symptoms in the lungs themselves. Right-sided heart failure is systemic. So it would show up in the veins of the systemic system. So in this case, what we're saying is one cause of secondary pulmonary hypertension is left-sided heart failure. Now we can have other problems, but all of them result, if it's secondary, result from an increased backward sort of pressure. So if there's a valve problem, we got the same thing. There'll be too much blood in the ventricle, which puts a pressure on the atrium, which puts a pressure on the pulmonary veins, which puts a pressure back on the lungs. Backward effects if the left side of the heart is faulty. Now, if you have chronic obstructive pulmonary disease, it can increase the hypertension in the pulmonary circulation, but initially at least, it didn't involve the heart. But so that would be COPD. And we're going to talk about COPD very, very shortly. And there is something called, I'm just going to write it down, something called cor pulmonale. I think we mentioned it in the recording. If not, it's definitely in your PowerPoints, and it's definitely in the textbook. But cor pulmonale is a situation where there's pulmonary hypertension because of a pulmonary problem. So the most common cause for pulmonary hypertension is left-sided heart failure. But you can have scenarios where it comes initially from the lung tissue. So it might be from COPD or some other pathology to the lung tissue. So if it comes originally from lung tissue and causes right-sided heart failure because of this relationship right here, then that is referred to as cor pulmonale, right-sided heart failure because of a lung pathology that caused pulmonary hypertension. Okay, and the concept for any of these scenarios is the same as what we've talked about all along. Our first goal would be to treat or get rid of the underlying cause if we have that option. If not, we have to treat with things that are designed to reduce the hypertension. So vasodilators or diuretics. The vasodilators are designed to try to increase oxygen delivery, and the diuretics or other medications would be designed, like again in that recording we talked about, reducing oxygen demand. So treatment with cardiac problems and to some degree lung problems is going to involve addressing oxygen demand as well as oxygen delivery. Okay, a couple of quick things before we get into chronic obstructive pulmonary disease. What time do we finish? Around 4:15 do we finish?
4:10, but whatever.
Yeah, okay. Yeah, I got another group right after you guys, so I have to be aware. So there's a term we're going to be talking about a little bit later that's called bronchiectasis. It sounds and looks a lot like this one. This is atelectasis. The issue is they don't really relate to one another. So it's terminology we need to be aware of. So this is a general term for the collapse of the lung or part of the lung. And for example, if the alveoli deflated because of COVID-19 and the destruction of the type 2 alveolar cells that no longer can produce surfactant. So the alveoli deflate is an example of atelectasis. So that's because of a decrease in surfactant. And of course, the problem with anything like that is we're going to decrease the surface area available for gas exchange. So we're going to have a problem with that. So who's most at risk for this kind of a problem? It can sometimes happen what we call spontaneously, but almost never truly spontaneously. But smokers, and the elderly are at risk for this kind of a problem. So the other thing we need to be aware of, just in general terms, is what happens with aspiration. Aspiration is a fancy word for choking. So this is when contents that were meant for the esophagus end up in the airway. So you might remember that the esophagus is a muscular tube that basically, when it's empty, is, more or less closed. But the airway is held open by trachea, by tracheal cartilage. And the cartilage is almost completely surrounding, but on the posterior side of the trachea, it's a little bit open, and that's where the esophagus kind of runs down in between. But these tracheal cartilage rings hold the airway open, so it's always open. So the esophagus might be closed, the airway is open, or it happens when the epiglottis doesn't effectively cover the airway. And that's more likely to happen if, one, you've been drinking, two, you're under the influence of some other types of medications, opioids, and or worse than that. Not too much worse than opioids, but you know what I'm talking about. Maybe more like street drugs that you're not as aware of in terms of composition and that sort of thing. Or the very young or the very old could be susceptible, or talking while you're eating. When you talk while you eat, the epiglottis is got to be open for the speak part and should be closed for the eating part. And when you mix the two, sometimes you pay the price. And that might be that something gets into the trachea. And again, just like we talked about with an embolus, as long as the opening is large enough, that piece will continue to flow. And from that first picture that I drew here, we can see that if that piece comes down, we take a chunk in and it goes down. It's small enough to pass, and the direction of least resistance is going to send it to the right side more often than the left, and eventually it's going to hit an airway that is too small for that piece to continue on through, and everything past that spot, it's going to stop getting airflow. That's going to severely restrict the area of gas exchange. This person would be in distress, but much more so if the lodging occurred before we got to the lung itself. And that would mean that all lobes of this lung would be left with not receiving oxygen. So eventually what's going to happen in that area beyond the blockage is that part of the lung is going to collapse. There's no reason for it to stay open if it's not exchanging gases in the interest of ventilation perfusion. And this probably represents a situation where compensation is going to go to decompensation very quickly. Why didn't we lose that? Okay, where are we? 12? So we're on aspiration. Let's see if that works. Okay, yep, we're on the right one, it looks like, anyway. So when we talk about aspiration, that's what we're concerned about, is when a particle of food goes into the airway instead of the esophagus. So you used to call that going around down the wrong tube, but now we know the anatomical terminology, right? So we should probably be using it. Now, if it's small enough, we can cough it up. That's a fairly normal response. And if you're healthy and got good, strong muscles and can create a good negative pressure, or in this case, really a positive pressure, and force it out with a good cough, then it's not a problem. And that's the mechanism behind the Heimlich maneuver as well, is to try to increase that reverse pressure to force the lodged particle out of the airway and back out the mouth. But if you're impaired for any reason, then we're going to have some complications. So again, mention some of the things: somebody that has a traumatic brain injury, somebody that's maybe under the influences of alcohol or drugs of some sort, people who are obese or a little more at risk for this kind of thing. If they're in other, altered states of consciousness, maybe coming out of a general anesthesia, one of the reasons they don't want you eating before a surgery, that sort of thing. And the problem is, of course, we're going to have obstruction. That leads to hypoxemia. And that can be life-threatening. Okay. So we understand a little bit about why we should not talk when we eat. That's what we just learned there. Everybody's really glad to learn that. Now let's look at some specific. Actually, should we take a break? Maybe we need to take a break, eh? Okay, we're back. We're recording.
Also, perhaps.
Yep.
Okay, good. I was just going to say, just before you start, I'll be leaving just before 4. I know it's not a big deal. I just wanted to let you know.
Yeah, okay. Appreciate it. You're here for most of it. You can see about half the class is not. Interesting. But, that's the way it is. So let's look at some specific disorders. So what we want to look at in particular, this next sort of group are described as being obstructive.
Sorry, I just wanted to clarify. Are we still on secondary pulmonary hypertension?
Nope. We're on a new category, obstructive disorders.
Okay, thank you.
Okay, so in respiratory system, generally, pathologies are divided up into being either obstructive or restrictive disorders. We're not going to talk too much about restrictive disorders, but restrictive disorders are examples of scenarios where for example, there's so much scar tissue in the lungs that they can't expand and retract effectively. That would be restrictive from scar tissue, repeated traumas or other pathologies that affect the elasticity in the lungs. Obstructive are affecting the airways. So they're blocking airflow for any number of reasons. So in all of our obstructive pathologies, there's a resistance to airflow. And that's either because the lumen wall, in other words, the opening of the airways, there's pathologies to the lumen wall that don't allow it to, for example, dilate effectively when signaled by the sympathetic division of the autonomic nervous system. There's abnormal pressure. On the opening of the airway. That's what happens if there was a tumor. We'll see it in emphysema. We're going to talk about emphysema. We don't talk about cancers in 301. You're going to talk about those in 401. Or there is an actual blockage. In the airway. And that might be from aspiration, like we talked about before the break, or from a lot of excessive secretions, which we'll see happens in asthma in particular. And we're going to start by talking about asthma. So basically, like most pathologies, you try to figure out a way to sort of briefly and concisely describe what's going on with the condition that helps to get you further along in the pathophysiology or whatever the case might be. So when we talk about asthma, we want to recognize that the presentation is variable and typically, especially early on, reversible. Okay, but the inflammation or the obstruction is caused at least in part by inflammation in the case of asthma. So inflammation of the airway and usually there's going to be some sort of a recognizable cause, stimulus. So because it's variable and reversible early on, like I say, when asthma is long-standing and the presentations are happening with more frequency, there are some irreversible changes that can develop. But we're talking about typically now, not in extreme scenarios. So when we look at the signs and the symptoms, and this is going to be to compare against other types of obstructive diseases that we're going to be talking about. So this is one of the ways we're going to be able to differentiate. So in asthma, the presentation is often sudden and is going to present with some wheezing, difficulty breathing. There's a cough because there's some production going on within the airways that we're trying to clear. And there's constriction of the airway. So I use those square brackets facing each other as contraction or constriction, in this case, of the airway. And lots of secretions. There's a phrase we're going to use in a few minutes that's sort of classic for describing the pathophysiology of asthma. And it's from these two factors that we just listed here: contraction or constriction of the bronchial airway and the increased secretions that are produced. So what we really summarize that as is bronchospasms and mucus plugs. So if you're trying to think of the pathophysiology behind an asthmatic attack or manifestation, think bronchospasms and mucus plugs. That's really what these two things are describing. So now we just want to figure out a little bit more about why that happens. So asthma is a relatively common condition. About 10% of the population worldwide has some form of what's called extrinsic. So let me just put up here. There's extrinsic and intrinsic forms. So we'll talk a little bit about each one of them. So we might as well talk about extrinsic asthma first. This is the one most of us probably think of. It's also sometimes just described as the allergic type, and the extrinsic refers to the fact that it's some sort of an external stimulus that is the trigger. So it's outside of the body. It's an exposure that the individual is presented with that initiates the response. So again, there's probably going to be a history of allergies in the individual, if not in the family. And the key thing to remember about this type of asthma is that it's IgE mediated. We talked about this a little bit when we looked at type 1 types of hypersensitivity. So remember, there's an IgE mast cell complex that's going to match up with a specific antigen. So again, there has to be some sort of previous exposure to initiate this reaction in the first place. So this is going to basically be occurring in the airways. Previous exposure to mast cells and sometimes basophils, and then they degranulate during the reaction and release their chemicals like histamine and interleukins, other signalers that will ultimately be responsible for the presentation that we briefly looked at on that previous slide there. So that it's these chemicals that are going to give rise to the bronchoconstriction and the increased mucus secretions and inflammation and all that sort of thing that's going on. So like I started to say, about 10% of the population worldwide has this type of asthma, this type of extrinsic form of asthma, with a much higher prevalence in more developed countries. So it's possible that the reason why we see more in the so-called developed countries is because there are more triggers, more environmental triggers, more allergens that people might be exposed to, but also because there's probably a more sensitive diagnostic criteria in the more developed countries. So it's diagnosed more, doesn't necessarily mean that it presents any different in some of these other countries. So between those two things, we know that there's an increased prevalence in developed countries. And the location for the pathology, and that's important again to differentiate from other types of obstructive diseases, is in the smaller bronchi and bronchioles. So further down that tree of branches. You know, you go from the trachea to the primary bronchi, secondary bronchi, tertiary, so on and so on and so on, progressively smaller and spreading out like roots of a tree or branches of a tree. And ultimately, you're going to get to bronchioles, where some of the respiration is going to occur. Respiratory bronchioles, terminal bronchioles are the ones that finish in the alveoli tree. So we went from trachea to a primary to a secondary. We don't have to remember all that. Constantly branching to finish on a terminal bronchiole that will supply air to individual alveolar ducts, to individual alveoli, and those alveoli are surrounded by a circulatory system, the pulmonary capillaries. So this is, we're talking about in the smaller bronchi into the bronchioles. That's sort of the target area for asthma in general, and we're talking specifically right now about the extrinsic form of, and the key thing to remember about the extrinsic form is it's going to be IgE mediated. That's the difference between it and the other one that we're going to be talking about, intrinsic. So basically what happens, the so-called pathogenesis, because of the damage that's caused by this IgE-mediated reaction, allergic reaction, and the release of these chemicals, the airway epithelium is interrupted because of the inflammation and the destruction that's caused by the neutrophils and the monocytes / macrophages that arrive at the inflamed area and start to destroy that epithelium. It's sometimes described as being denuded, a more technical term, but just think of it being destroyed, destructed. Then we're going to get some collagen deposition. We've seen this progression before with injury repair and attempt. We know with inflammation there's going to be edema. We know the mast cells are all part of this puzzle. That's where the inflammation and white blood cell activation comes from. Then we talk about the bronchospasm. And when we talk about mucus plugs, so what we're saying is the mucus is copious, lots and lots of mucus. It's thick, and it'll block some of these airways completely with how thick it is. And in the smaller airways, they'll actually get complete blockages of some of those smaller airways, forcing VQ mismatch, right, or ventilation perfusion mismatch. Then we're going to get airway remodeling with recurrences. So the more often these exposures are, the more likely there's going to be some remodeling. Now I've got a picture to show you that'll illustrate a little bit about what we've been talking about. So here we look on the left, up in front of your screen on the left, you can see we're talking about a normal arrangement of the airway. So here's our pseudostratified columnar epithelium on the inside. We've got some smooth muscle that can respond to the autonomic nervous system for dilation or constriction. We got some mucus glands. So this is like a submucosal layer of this airway pathway. A nice open lumen and nice organized layers below that epithelium. In asthma, especially with repeated episodes, we're going to see these represent the cartilage, incomplete cartilage rings in the medium-sized, more so than small or bronchioles, but that's why they throw this cartilage in here. So we can see overproduction of the mucus glands, and we see, this is not very well illustrated, but the smooth muscle cells, they eventually become a little hypertrophic and oversized and create an irregular lumen opening. And what's being shown here, not very clearly, but is the production of a lot of mucus. That's what this in here is. You see in this picture, we didn't see any significant accumulations of mucus, but in this picture, we've got a large accumulation. So this really represents, especially if we saw hypertrophy of smooth muscle, really represents a structural change that happens as a result of repeated episodes of asthma. So this would be a chronic, repeated exposures to the stimulus that was causing the pathology in the first place. So anytime we have this degree of disruption, we're going to see that we're going to get some loss of strength of the airway integrity. We're going to get permeability between blood vessels that supply this tissue because of the chronic inflammation and that sort of thing. All magnify some of the symptomatology that's associated with this. Now, the biggest concern we have is not so much these temporary types of attacks. They're sometimes called asthmatic attacks. And some of you are probably, either if you have never experienced it yourself, you probably know somebody that has. And they can be very mild and they can be very significant. But the biggest concern long term that we probably have in these people are what's called anaphylaxis. So a concern we have in any kind of an allergic response is anaphylaxis. And what seems to happen in anaphylaxis is with repeated exposures, with repeated exposures, the sensitivity to the stimulus gets stronger and stronger and stronger, and the reaction becomes more systemic, less local and more systemic. Increased sensitivity to the allergen and the risk of a systemic response. with a systemic response, you're going to get inflammation and increased permeability. Of blood vessels. Which is shock. Shock is all about blood pressure dropping to a level that can't be compensated for, and it becomes life-threatening. So in anaphylaxis, you're going to have the same sort of extreme response in the respiratory area, bronchoconstriction, mucus plugs, and systemic-wide permeability, giving rise to a drop in blood pressure if it's significant, loss of cardiac output, and death becomes a real possibility. So this is a medical emergency, and the medical emergency can be corrected with that particular response, or that particular episode can be corrected with epinephrine, right? Mild attacks are often used with beta agonists trying to promote vasodilation, beta 2 agonists especially that promote bronchodilation. That's what is often, that variant is in puffers that people will take, inhalers that they have that they carry with them. But in an anaphylactic type reaction, it's much more serious and requires much more significant treatment. And that's where the EpiPen comes into play, or epinephrine administration in a hospital setting as well is the other option in that case. Now, in intrinsic or non-allergenic asthma, so where the extrinsic type is more likely to be present in children, especially because of the allergy component associated with it, is going to be picked up in a younger population. This is a little more common in the older populations. It's often an older onset, maybe people in their 40s to 60s might sort of seem to develop this type of asthma. The pathophysiology is the same, except the trigger is not an IgE mast cell complex trigger. So it's not an allergy trigger. So the triggers are often environmental factors. So we're just going to make clear it's not IgE mediated. So environmental factors like cold air causes a reactive type of bronchospasm when the bronchial airways are exposed to that extreme temperature. Exercise, where there's a call for bronchodilation, but instead we get bronchoconstriction. Some people will have an intrinsic response to aspirin or alcohol. And these triggers do activate mast cells, but not mast cells that are associated with the antibody IgE. So the mast cell reaction still occurs, so all the rest of the pathogenesis will be very similar. Promotes inflammation, permeability, mucus plug formations, bronchoconstriction, all of those same things are going to happen, but the trigger was different. Okay, now in either or in all types of asthma, Okay, let's just write this down. Not IgE mediated, but the pathophysiology other than the IgE. Everybody understand what I'm writing there? It's not IgE mediated, but everything else is the same. So when we wrote down all those things, I think, do I have it on the previous slide? Maybe on this slide. Airway epithelium, all of this still applies. All of this stuff is the same. The initiation was IgE mediated in extrinsic. It is not IgE mediated in intrinsic, sorry. Are you okay with that?
Yeah, thank you.
Okay. So in all types of asthma, what we're concerned about is not so much getting the air in. The issue is expiration. So the problem is difficulty or trouble with expiration. If you've ever experienced it or seen someone going through an asthmatic attack, you know exactly what I'm talking about. What they will start to, essentially they start to overinflate their lungs because they can get air in okay, but the plugs are more significant at trying to get the air back out. So the lungs become overinflated. And that shows as someone looks like they often will show contracted sternocleidomastoid and scalene muscles. Their rib cage will be in an expanded position pretty much all the time, especially someone who's subjected to repeated exposures to whatever their triggers happen to be. So they look like they're in a constantly inhaled position, like big increased anterior to posterior and to some degree longitudinal expansion of their chest. So they're having trouble with getting rid of the air, not so much getting it in. And another thing to be aware of when we're talking about asthma is a condition called status asthmaticus. So this is a really severe acute that doesn't respond to the standard treatments. So the beta-2 agonists are not helpful. So this becomes life-threatening because this is going to lead to respiratory and or cardiac failure. So imagine that pathophysiology doesn't stop. So it's not reversed. So there's going to have, these patients are going to have significant interventions, including mechanical ventilators and aggressive medications for the bronchodilation. To be able to occur. So it's a subcutaneous exposure to epinephrine and other beta-2 agonists in an aggressive way, much more so than what would be available for someone to carry around with them for self-medication purposes. So in terms of treatment, let's see now, where do I have to go? So the treatment really doesn't change for all of the conditions that we're going to be talking about. In case of treatment, what we're looking for here is trying to decrease the inflammation. And we're trying to promote bronchodilation. Because the immediate issue is the difficulty with breathing, inability to get a good oxygen carbon dioxide exchange going on. So beta 2 agonists are effective particularly for addressing the bronchodilation. Corticosteroids, we know, are what? So why did I write the corticosteroids up here? What do we know about corticosteroids?
They're anti-inflammatories.
There we go. There was no trick there. I was just trying to get some engagement going on there. So epinephrine is more of an emergency utilization. The trouble with epinephrine in less than emergent type scenarios is epinephrine is very non-selective. So not only will it promote bronchodilation, but it's going to also increase the risk of cardiovascular reactions. So if we already have a lung problem and we compound that with increased demand from the cardiac system, we may compound our problems. So we say that the epinephrine is effective in emergencies, especially if we're concerned about anaphylaxis and that sort of thing. But otherwise, it's not a treatment plan that we would use for recurrent attacks, recurrent so-called minor episodes of asthma. So the preferred treatment, preferred mode, are through nebulizers. Do you know what I mean by a nebulizer?
A puffer?
Yeah, puffer. Those are inhalers. So yeah, that's all that's referred to. So they're very easily absorbed when they're inhaled that way. So their response is going to be fairly quick. Now, one of the things we have to be aware of, hopefully you're probably aware of it by now, but well, you know what? I better put a different color in there. We know a little bit about this already when we talked about the stress response. We talked about elevated levels of cortisol and how it can have negative effects. We're mostly concerned about protein breakdown that might lead to osteoporosis or muscle weakness and immune deficiencies. So those are the sorts of things that we're concerned about there. Now we can also add oxygen therapy, in the treatment plan as well to alleviate the hypoxia. So again, if this is a type of attack that's gone on for a little bit longer, then the oxygen therapy might be a desired addition to the treatment plan as well. So the issue we have with patients that have had asthma for a long period of time is that the airway restriction reduces air oxygen delivery, so we're dealing with a hypoxic hypoxia. So when you hear that combination, hypoxia, it's because the delivery of oxygen to the exchange area, to the lungs, has been reduced. So other examples of hypoxia could come from atmosphere, right, where you've got less oxygen in the air to begin with. So that's a type of hypoxia. And in this case, what we've got, if there's airway restriction, it's a type of hypoxia as well. I probably should have gone over with you the different types of hypoxia. Let's, just while we're on that topic. So when we look at hypoxia, we know what the definition is. So there's a couple of different subcategories of hypoxia. So in situations where there's a blocked airway, if there's high altitude, so we're talking about scenarios where the source of oxygen is reduced. So altitude is a good example of that. A blocked airway, that's what's happening in our carbon monoxide. So carbon monoxide is an example too, because the carbon monoxide competes with oxygen and interferes with the delivery to the circulatory system. Now, if it's called anemic hypoxia, where do you think the problem might be there? If it's called anemic hypoxia,
In the blood?
yeah, so basically those are scenarios where there's decreased oxygen delivery to the cells. So in situations where there's certain types of anemias, there's a thalassemia, sickle cell. Those are scenarios where the hemoglobin is not behaving properly, so we're not getting good saturation in the hemoglobin molecule, and it's reducing the oxygen delivery to individual cells. That's reduced hemoglobin capacity. Then we can have cardiac hypoxemia. And if it's cardiac hypoxemia, it's decreased O2 delivery because of decreased cardiac output. So that's another reason we would get poor delivery to our tissues. I think that's pretty obvious. And this last one is sort of an interesting one. It's described as histotoxic. I'm missing a whole syllable in there. Histotoxic hypoxemia. So in histotoxic hypoxemia, what we have is normal delivery to the blood. So the respiratory system is working, the circulatory system is working, but we have abnormal pickup at the cells. So, for example, cyanide poisoning. We can get ways of we've talked about we mentioned carbon monoxide, that's a type of poisoning. Now here's another one. But what cyanide does is at the cellular level, it blocks an enzyme from allowing the mitochondria to make ATP. So you might as well not have any oxygen. So it blocks ATP synthesis in the mitochondria. So we have normal delivery, but abnormal pickup or utilization. So normal delivery. So in the ones above, we had abnormal delivery. Either we didn't deliver it properly because of the source, up in number 1, because of hemoglobin issues in number 2, and because of heart issues in number 3. But in histotoxic, we got normal delivery, but abnormal utilization. So those are different reasons why tissues won't get an adequate oxygen supply, and as a result are going to be in some kind of distress. Okay, now what else do we need to know about our... So we can get a little progression going here when we look at what the issue is with asthma, especially long term. So what we're talking about is we're starting with airway restriction because of that bronchoconstriction, causing hypoxia. And if we have hypoxia, particularly having a problem with expiration, what acid-base condition are we setting ourselves up for? Well, first of all, with hypoxia, what's the response going to be? Right? We're gonna compensate by increasing our respiration rates. We're okay with that, right?
Yes, thank you.
Okay, but if we increase our respiration rates, what's that going to cause from a pH perspective?
It's going to make it more basic.
So we call that respiratory alkalosis, right? And that's a type of compensation. But eventually that compensation is going to fail. So what we get in asthma is we get that air trapping where the carbon dioxide can't be unloaded effectively. And that's going to create respiratory acidosis. So when we're in the hyperventilation mode, alkalosis, but when we are failing to eliminate carbon dioxide effectively, carbon dioxide levels go up and acid levels parallel carbon dioxide levels. So we're going to end up now with a condition of respiratory acidosis, which really represents decompensation. And from respiratory acidosis, that's going to have a dramatic effect on the control centers in the brain for regulating ventilation. So we're going to have severe respiratory distress because the signal is still going to be to try to increase respirations, but it's not effective. So now we've essentially described respiratory failure. And with respiratory failure, we're going to look blue. We're going to have a decrease in PaO2, probably somewhere under 50. These are the numbers we talked about earlier, I think, today, and elevated levels of partial pressure CO2 over 50. And this is trouble. That's what we call a poor prognostic sign. Indicates that the increased ventilation rates did not effectively compensate. Exhaustion is imminent. We know that what happens with exhaustion when we talked about the stress response. And if this is happening on a repeated basis, then we're going to get remodeling, and those are irreversible changes as far as that goes.
Sorry, do you mind explaining this whole chain again? So I got lost with the respiratory alkalosis. So the hypoxia leads to the compensation, which is increased respiration,
Right.
and that causes respiratory alkalosis.
Right. Right. And you should
Okay.
from you did acid-base balance.
Yes.
And if it's a problem with the respiratory system, then it's described as a respiratory condition. Okay. If it was an alkalosis for some other reason other than respiratory, it would be called metabolic.
Right.
Right. But because this problem is originating in the lungs because of the asthma in this example, the response to the reduction in air oxygen delivery is like it would be for in any scenario was to try to increase the oxygen delivery by increasing your breathing rates. Right.
Okay.
And what's going to immediately happen early on in this response, that early respiration compensation is designed to try to eliminate CO2.
CO2. Right.
So as a result of that early elimination of CO2, you're establishing potentially a respiratory alkalosis. Okay. Now, because that's not going to work in the case of somebody with asthma, because their air is being trapped behind those plugs, the carbon dioxide doesn't escape. So instead, we're going to develop acidosis because of the failure to eliminate carbon dioxide. So it's a progression. Right? It's like early on we got a bit of compensation, but it didn't last very long. So now we're breaking down. The compensation is not working. The opposite of compensation is decompensation. Right. So what's happening because of the trapping is acidosis, and that's going to affect your nervous system to get all excited. That's going to result in severe respiratory distress. Remember, we mentioned, and you need to review your chemoreceptors if you're not that familiar with what we mentioned very quickly at the beginning today. But the chemoreceptors are particularly sensitive to elevated CO2. That's what we're describing here, is elevated CO2. So that puts us into an emergency response, severe respiratory distress. Can't be fixed because of the underlying pathology, failure.
Okay. Yeah, that makes much more sense.
So now, and the blood values will be what we just wrote down there on that last line. So the O2 is dropping. Remember, we're pretty happy with a PO2. If it stays above 70, we can manage just fine. But when we get below 50, that's an emergency. And a PaC2 we're much less tolerant of. So normally it would be 40 or 45 if it was in venous blood. Now it's above 50. That's an emergency.
Right. Okay.
Okay. So that these types of pathways are important ones to be able to follow. So it's a good question that you had to get it clarified, and you can sort of see why as we move along the pathway. You should be able to visualize why that's happening, like the air trapping because of the plugs, the hypoxia initially because of bronchoconstriction. So we can adjust to bronchoconstriction alone by increasing respiration. But as soon as those plugs start to trap, now we can't overcome that. Now we're in trouble. Does that make sense?
Yeah, thank you.
Okay, let's see if so I showed you the picture of extrinsic asthma. Let's see, we got about 15 minutes or so, so let's introduce chronic bronchitis. Okay, and then we'll get the rest of the respiratory system finished next week. Chronic So this is sometimes called type B COPD, chronic obstructive pulmonary disease, COPD. So this is type B. We obviously haven't talked about type A yet. We're going to talk about type A after we talk about type B. So the classic at-risk individual is a male more than a female, by about a 2-to-1 ratio. And that's because of a lot of modifiable factors that come into play. It often begins in the 30s and 40s. It's a progressive condition that starts off almost what we call insidious, in other words, not very noticeable, with some shortness of breath, especially on exertion. And you can inevitably, through your examination and history taking, walk them back to where they first started to notice it. Well, not necessarily first started to notice it, but to get a picture that it was a gradual onset. So I think I've used in class, I've used the example of, the person that would go up and down the set of stairs several times in a day, maybe doing the washing and drying down in the basement, and they would go and do the washing and drying once a day for 5 of 7 days in the week. And then they noticed that the exertion of going up and down those stairs was more taxing. So they started maybe doing it 3 times a week, and then they're down to once a week, and maybe now it's once every 2 weeks, because they just can't get the energy up to go up and down those stairs. That's a gradual onset. That's an indicator of either cardiac failure or, in this example, chronic obstructive types of bronchitis. And sometimes it's chicken and egg. You don't know whether the weight issue was part of the onset or part of the result of this type of chronic obstructive scenario. The diagnosis is going to be made symptomatically because there isn't a lot of classic signs and symptoms that are going to point to it. But what else did I want to say about this profile here? Oh, the other thing is probably around the most common risk factor associated with chronic bronchitis is from smoking. So by far and away, that's the one common denominator in this type of bronchitis problem, this type of chronic obstructive condition. More than 90% of the patients will have smoking in their background. And the pathophysiology repeated exposures to what we generally would call respiratory irritants. So technically it can come from smog in the city. It can come from anything that's floating in the air that has the potential to cause an irritation. We mentioned that the lungs are, by design, supposed to be pretty much sterile. So anything that enters into the lung tissue is potentially harmful. So if there's repeated exposure, smoking is the classic example, then people that are subject to chronic infections or multiple infections. And that's a double-edged sword because people who have chronic bronchitis have a compromised immune system when it comes to the lungs, so they're more likely to get infections, which is just going to make the condition worse. So you don't have to be a smoker to have this kind of repeated exposure, but it's much more likely to happen in those that do. So the whole idea is, again, we're going to start with inflammation. And the inflammation is going to lead to localized edema and attempts at repair. And that repair is going to lead to some scarring. We know with scarring we have loss of function, and that's where the obstruction comes from. Loss of elasticity in these airways, so they're not going to be as responsive to the autonomic nervous system, calling for dilation or constriction to occur. We get the mucus production. You can see why a lot of the pathophysiology with what we've been talking about up till now looks a lot the same as asthma. That's why the treatments will be very similar in terms of the goals of treatment, trying to improve airway flow and trying to reduce demands. But the big difference here is because of the chronic exposure to these irritants, you're going to get hypertrophy, and hyperplasia. And those might lead to metaplasia, cancer. Most of us are generally aware that one of the biggest causative factors or risk factors associated with lung cancers is smoking. And that's the same mechanism so it doesn't always lead to metaplasia. That's why I put the asterisk there, but it can lead to metaplasia. But that reduced elasticity and the scarring and all of that stuff leads to obstruction. So that, and again, because it's chronic in its development, COPD. That's where the terminology comes from. Decreased So again, these patients have what we describe as a productive cough. The secretions that are created from initially the inflammation and the edema and the mucus production, and the weakening, scarring, decreased elasticity, loss of the ability to clear. So that was that mucociliary clearance function, as well as the strength of the muscles around the respiratory system, reduce the ability to clear those secretions. So they're coughing on a regular basis, particularly when they change position. They go from sitting to standing or lying down to standing, and the reverse, from standing to lying down. The cough is often going to be a little more productive during those times, those changes of position. Now, the pathophysiology of what this looks like compared to asthma is somewhat similar. So here in chronic bronchitis, Okay, we're talking in little bit larger of the airways, so not down in the smaller bronchioles and smaller bronchi, but in the more medium-sized to larger-sized bronchi is where we're going to see the hypersecretions and the changes that occur. So here we had a nice healthy one in this picture. So the airway is open without a lot of extra fluids or anything like that. And in here with the inflammation and the excess mucus, we get a change in the lumen opening with some pockets. And within those pockets, we have leaky blood vessels. And this is supposed to represent secretions that are filling up that space. So they're going to interfere with airflow in and airflow out. So again, what we can do is we can look at this picture and we can follow the pathway and we can see that what we're going to have here is airway restriction and secretions. Those secretions are mostly mucus. So that's what sets us up for our hypoxia. So we would get compensation. And then decompensation. The decompensation would then show up as cyanosis. And hypercapnia. This local edema, this edema, as a result of that chronic inflammation, increases pulmonary hypertension, otherwise known as cor pulmonale. And we know that the cor pulmonale is going to lead us to right-sided heart failure. So what started as a lung airway problem has become now a cardiopulmonary problem. So how are we going to treat it?
Sorry, I have a question.
Oh, yeah, go ahead. Actually, I want to also, before we get to treatment, we should talk about what this patient's going to look like. Go ahead. What's your question?
So it's pretty similar to asthma. So like, how would you differentiate that?
Well, a couple of things. One is this is chronic, where asthma was intermittent. So that's a big difference. We're going to do a chart when we're going to talk about emphysema, and then we're going to compare all three so that we can pick up the differences. Also, the location. For asthma, it was the smaller bronchi and bronchioles, and in chronic bronchitis, it's more of the medium-sized bronchioles bronchi that are going to be affected.
Okay, thank you.
Productive cough, chronic cough, as opposed to the asthmatic attack type of thing is a big difference too. But you're right, as far as the airflow goes, there's a lot of similarities. So in our COPD type B, which was our we keep mentioning putting that word chronic in front. That's important because there is such a thing as acute bronchitis. Acute bronchitis, though, is not typically a medical emergency. Acute bronchitis is just like it sounds. It's an acute. It's often a one-off. So you might see some inflammation, you might see some secretions, and the individual might cough, but it's part of an infection that is temporary. If this person is otherwise healthy, they ride through that infection and they clear it and they recover and they're none the worse for wear. But repeated episodes of acute bronchitis because of smoking or because of chronic exposures to irritants and so on can lead from acute to chronic. But acute by definition is a one-off episode, as a result of, a single stimulant that has irritated and has a defined period of time that allows for a full recovery. Chronic, we've talked about this progression now. So these guys are nicknamed the blue bloaters because they're often obese and because they have systemic edema due to the right-sided heart failure. They look puffy. So that's the bloater part. And the cyanosis is the blue part. But otherwise, they're going to have difficulty with breathing. That's not a surprise. They're going to be very tired because they're not getting good oxygen delivery. So they're going to be sedentary, even if they weren't at one time or another. They probably are going to have that pulmonary hypertension. We got a cough that's worse in the morning, and that's mostly about postural change. And to be diagnosed as chronic, that cough probably has to be present for at least 3 months, more than 3 months duration, but it is pretty consistent. And we expect to see an increase in heart rate and an increase in ventilation rates. And, that's all about the compensation or attempts at compensation. So how do we fix it? We have to address, again, the cause, which in this case is the irritants. If they're a smoker, you got to get them to stop. They probably won't very easily because this is a gradual onset. They've had a long time to recognize that something isn't right. So not always are they going to listen to you just because you tell them what's best for them. Expectorants, that's a class of medications that are going to help you expel, get rid of that phlegm, get rid of that mucus buildup in the lungs. Dilators are your again, going back to your beta 2 agonists. Everybody's good with agonist versus antagonist? Yes? No?
Yes.
Okay. Low flow oxygen is going to be administered whenever your partial pressure of oxygen is less than about 55 millimeters of mercury. Don't need it if it's still above that, but it's recommended once it drops down below that number. Complication that can develop, and we'll finish on this point. So what can happen is that chronic breakdown of the bronchial leads to dilation, pockets of dilation. And that's got its own name. That's that other name I mentioned earlier, bronchiectasis. So that's where parts of the bronchial airway are weakened and expanded, like an aneurysm was in a blood vessel, followed by arrows of narrowing, and those become pockets that provide a little focus for bacterial infection, and secretions can pool in those areas, and they begin to degrade in those areas. So we get pooling of secretions. So those secretions become stagnant and become a source of infection, and they can really, really stink. So the cough becomes a really smelly, odorous cough, and the presence of bacteria that's breaking down gives the sputum, the mucus that's being coughed up, a greenish, yellowish appearance to it as well. So you're getting infection, mechanical stress, mucus plugs, foreign bodies, everything that is a complication that's more likely to occur in chronic bronchitis than in asthma, another difference. But this would have to be fairly advanced for it to occur.